Welcome to the Accidental Experts podcast. I'm your host, Bryce Hamilton. I'm a licensed clinical social worker and a child and family therapist. I have been in practice for over 15 years, and I'm also a mom of 4. So I know the challenges both professionally and personally. I'm so glad that you're here today to grow your parenting toolbox. Please come as you are and be ready to learn. My goal is to make you the accidental expert so that you can raise healthy humans. So we have a special guest today. Her name is Lindsay Baldridge, and she is a pediatric endocrinologist. So Dr. Baldridge is going to talk to us about how to parent through identity exploration and about what the endocrinologist does in this process. With that, let's get to Dr. Baldridge.
Thank you.
Yes. Okay. So we're going to be talking about gender and exploring gender and how parents can support our kids through that process. And it's not a process that everybody goes through, but some kids and teens do. And so we're going to talk about that. But before we get to that space, can you talk to us this space in adolescence? Actually, you know what? Can we do something first? Can you introduce yourself? I'm so sorry. I am so excited to talk to you about this. I just jumped ahead. Start with
Sure.
talking about what you do.
Yeah, so I'm Lindsay Baldridge. I'm a pediatric endocrinologist at an academic center in New Mexico. I see kids of all ages for hormonal issues, as well as diabetes care and transgender care.
Yes. Okay. Amazing. I'm so glad that you're out here. I just got so excited to talk to you that I was missing my first step.
You're fine. No
Yes.
problem.
Okay. So and also thank you for doing that, because I know in our house, we were looking at growth and did we have the right growth happening with one of my kids? And so your being a pediatric endocrinologist has impacted our life, not you personally, but just having somebody in our lives. And I have to make a funny comment of it was the first time I learned that you guys have little beads that represent testicle size. I was like, this is a real thing.
Oh, I usually have them in my desk here.
And now we don't have him to show anybody. But that's okay.
I know,
But
I'm
I was like,
sorry.
oh my
I
gosh,
usually
this
have
is so
them.
funny. But it makes so much sense. But I was like, my son was like, oh my gosh, embarrassment, totally, right? About oh my gosh,
Yeah.
it's awful.
Everyone is embarrassed, but I like to remind everybody I'm the puberty doctor, and unfortunately, I got to do this to pretty much everybody.
Yes. Yeah, it's part of your job. Literally. It's
Mm.
just part of the job, right? Yeah. Okay,
Yep.
so let's talk about this stage of adolescence, because like you said, you're the puberty doctor. And so we define adolescence as 11 to 25, which of course you know, but that lasts forever. And I think sometimes parents don't realize that it starts so early and ends so late in terms of adolescence. And that doesn't mean that puberty is going for that long, but that is how long it takes for our frontal lobe to fully develop. So when we're in this stage of adolescence, we are going through a lot of different challenges, a lot of emotional challenges. We're questioning our journey, right? Lots of questions about ourselves and our development. And this can also include gender. So can you talk to us about what is happening in the brain in terms of this part of development and why it might be happening at this stage?
Mhm. So, I think that I've got a few things that I want to say in response to that sort of prompt. With the first thing being that sort of the concept of gender and gender identity is something that actually starts happening pretty early on, even like around 2 or 3 years old, around when kids can first start talking. Now, that's not necessarily always their permanent gender identity, because, as you just said, the brain and the body is changing a ton throughout a child's life. So, um, while there are some kids who are gender diverse who realize it at a very young age, there are other kids who don't realize it until the teenage years, sort of when a lot of times it's when you start getting sort of those changes of puberty that start happening, that the feelings of dysphoria or not feeling right in your own body can start to happen. And so but in terms of gender dysphoria, this could also come even at later ages in life. I would say that it's a pretty pretty booming field in the terms of adult gender care, because while we've had gender diversity throughout the ages, of course, it's really been something that's been more taboo in terms of our society in recent decades specifically. And so I would say that there's quite a few stories that are coming out of people who did not realize that they were transgender until they were getting older.
Mhm.
And so that's sort of my first thought in terms of gender identity. And I want to come back to those teenage years that you're talking about specifically. So one of my kids is 9 years old, and they like to proudly tell me that they're practically a teenager.
Mhm. Yep.
um, and I like to gently remind them that they don't have any signs of breast buds just yet. So lucky for them.
Yes. Mhm.
um, but so it's really there are different stages of adolescence, and what can be especially nuanced in pediatric care is the different times that different kids are going to be going through those stages.
Mhm.
And in endocrine, we have sort of lots of pieces of the puzzle to look at to sort of determine where a child is at in puberty. And then using that can sort of give us a better idea of things like their maturity levels and sort of where they're at in their brain development.
Mhm.
Um, and so that then would raise, I think, more questions in terms of, well, if kids are sort of exploring these ideas about themselves, especially around the time of puberty and when those changes start to happen, then is there something that we should be doing about it? And I think that's sort of the big, like political question when you get to that point. But tell me what what questions do you have from that?
Yeah. Well, I was thinking, okay, so like as a psychologist or like brain science for me, I think, what I know about teenagers is we're trying on a lot of different hats, right? Like even outside of gender, just like the typically developing teenager is going to explore things including gender, like in that they're like affirming, yes, I do feel like I was born female and I do feel female. I like this expression of myself and that feels in congruence, or it doesn't feel in congruence. But it could also be like, I love horseback riding, but now I don't. Right. And also, I really loved science when I was in elementary school, but now that's like not my thing. And now I really want to be into art. And so I think parents remembering just this part of the teenage years are to explore. Like we are supposed to figure things out about ourselves. I mean, there are things, I'm 40, and there are still things as for a 40-year-old that I am still learning about myself. And so I don't think that the development or like that process concludes, but I don't know that it's as intense, right? Like I think I learn things about myself a little bit more slowly or intentionally versus like when I remember being an adolescent, it was like, I want to try this and I want to try that and I want to try this. And nope, don't like that. Oh, that's a terrible thing. And then I'm like, actually, I want to try that. Right. So I think there is a lot of normal development that is just exploration, like they're supposed to. And we want to encourage that. Is that how you feel as well?
Absolutely. In terms of, kids are definitely feeling things very intensely as teenagers. And it's true that the sorts of things that are influencing them are going to change as they go through those different stages of adolescence. You go from sort of listening to your parents and your family and sort of those sorts of influences, to, as you get a little bit older and you're trying to figure out yourself, you start looking to your peers more, and getting more influence from your peers, and then it sort of changes as time goes on, and does a lot of times go back to where kids end up then getting influence again from their parents as they're older. And so I think that is really helpful to illustrate that it's important to support children in terms of their ideas and thoughts and feelings during that time. And for gender and the sorts of things that I see, it's important to reassess the child's goals each time that their provider or physician, whoever they're seeing, is seeing them for that. So I think that it's important to point out that I really focus on a lot of the medicine parts of gender affirming care, because that's a big piece of what I do as an endocrinologist, and I sort of lean on my colleagues in therapy and psychiatry and social work to help sort of work through those ideas about gender, and in order to end up with that referral then in the pediatric endocrine office. And I think that when you're looking at seeing the pediatric endocrinologist, then some people can be worried that it's sort of that you're going there to do hormones, and that's the thing. You're going to go there, you're going to start hormones, and you'll have permanent changes from that. When we can see that, well, kids like to try a lot of things, and yeah, they're going to feel things really intensely when they're teenagers, and so of course parents can be worried about having permanent changes that their kids might regret later. And so in terms of looking at that, coming back to the supporting your kiddo sort of at that time, when you come to see the endocrinologist, that's going to be sort of one of the things we assess in terms of looking at the referral information we get, going through like the therapist notes and your PCP's notes and things like that, and also talking with the family and talking with the patient and getting all of those ideas to say, okay, so what are our goals here? Because we probably one of the biggest fears that we have as doctors is causing a permanent difference or permanent injury in a child that they'll have to deal with for the rest of their life. That's the sort of thing that keeps us up at night. And so we try to be very cautious when we are evaluating that and talking with these families to sort of see where each child is at for their journey. And it's not necessarily like each kiddo has one journey. It's very possible to have multiple journeys. When I was doing a lot of research into looking at regrets in terms of those patients who have transitioned, there's a very small percentage of patients who have mentioned things like regret, and those patients have typically all been adults who had surgeries. Because for the most part, there's basically no surgeries that are happening for children in terms of gender affirming care in most of the U.S. For the most part. And so when we talk about the things that we want to do to help support that child, I feel like the medical things are just this one piece of it. And while they come to the endocrinologist to consider that, it's good for us to be able to have those early referrals to go through the options that we have. And I say that particularly there's one protocol that comes out of the Netherlands. It's called the Dutch protocol. That it's not like the end all and be all like clinical guidelines of gender affirming care, but it is one of the primary studies that sort of started off the idea of this way of going about gender affirming care.
Mhm.
And what I mean by that is that if a child is maybe expressing ideas of gender dysphoria, it's typically coming up around the time of puberty. So in terms of people who are assigned female at birth, the first sign of puberty would be breast buds. The estrogen would cause the breast to start to grow. And then for people who are assigned male at birth, the first signs of puberty is the testes getting bigger. And as you mentioned, the orchidometer can measure exactly where they're at in puberty. And so if we're able to sort of see those kids before that happens, then once they start into puberty, there's the option of trying a medication to block the puberty, to give them some time to sort of figure things out without having to deal with the permanent changes of puberty that everybody has to go through, whether it's um, a masculine puberty or a feminine puberty. Everybody has to pick one for their body and bone health. And so, in terms of the puberty blockers, those are things that are very minimal in terms of side effects, and they are basically just a way to keep your body from going into puberty or stopping it. Basically, once it has started in puberty, rather than stop, it's more of a pause. It's not causing anything permanent. Like I said, it would be a matter of once you then stop the puberty blocker, then your body's natural regulation will kick in, and you start back into puberty where you left off. And so ideally, if you can get a kiddo started on that when puberty is first starting. And so we would say that that is a Tanner stage of 2. So right at the beginning of puberty, if we're able to stop it at that point, then there's minimal physical or permanent changes that can happen that they might have issues with later. And it can give them some time for their brain to sort of grow some more, and for them to get some other influences and things like that. So then the next question is then the actual gender affirming hormones. So like estrogen or testosterone. Ideally, so the Dutch protocol would be try to get the puberty blocked once the kiddo starts. Then that's when you can get them blocked. You can't start them too early because then they won't get into puberty at all. They will eventually, but that's not what we're trying to do. We got to get it right there at the beginning, and then from there. We can sort of see, what the kiddos' desires are. We can come off of the puberty blocker within a couple of years or 4 or 5 years, and it doesn't really matter necessarily the time, as long as we're going through puberty at some point during those teenage years. And then being able to give some of those affirming hormones back to start that process of the pubertal changes, so that number one, those kids can be looking more like their peers, and so they can fit in at that time. But number two, we want to support these kids in terms of helping them to decrease depression and suicide rates, because of course this group is very vulnerable for that. And then it's a slow process of the hormones too. So we typically try to mimic puberty, and so we start at a low dose and would increase over 2 to 3 years. And so that means that while those permanent changes are possible and likely to happen, it's going to be slow. And so, they're going to have times to sort of reassess things as they're going about it before they're just like really far down the road. And so we really suggest that and highly recommend that they continue to follow with a counselor or a therapist or their psychiatrist or all of the above during hormone therapy, because it's just hard enough to go through puberty for anybody, but then when you're going through puberty that is different from what you were assigned at birth, then it's a little bit difficult in terms of a lot of other things. So that's why we recommend to follow very closely. And so I think that sorts of brings about lots of other questions and issues of exactly who we choose to start and how we start. But I think that gives a nice overview of what sort of, I think, a good protocol that they use in Europe is, and that they have had quite a lot of success with, and very minimal regrets or detransition rates. Whereas I would say there's probably multiple transitions rather than a detransition.
Yeah.
Yeah.
Okay, so when you talked about the puberty blockers, like that is something that sometimes you do for a kid that is not gender affirming care that might be going into puberty just too early
Mhm.
too. Is that correct?
Yeah. And when we look at those ages of teenagers, right, 11 to 25 or so, so for girls, they can actually start puberty as early as 8 years old and be totally normal.
Mhm.
And by starting puberty, I mean breast buds. And so that means that once you start breast buds, it's 2 to 3 years after that that a girl or someone assigned female at birth will actually have a period or menarche. Um, and so, if girls can start as early as 8, then they can typically start having periods as early as 10 years old and can be normal. Now, sometimes there are cases where kids will start to show those signs as early as like 6 or 7 years old.
Mhm.
In girls, I feel like it's kind of harder, or kids who are assigned female at birth, uh, the age of puberty start has really gotten a little bit earlier and earlier as years have gone by,
Mhm.
and we don't necessarily have a good explanation for that, but it's also not necessarily causing any problems that we can see.
Mhm.
The big thing would be maturity levels in terms of starting to have periods, and so typically, even if they're around 8, by 10 years old, that's an okay time for most
Mhm.
kids to
Mhm.
start. So, in terms of kids who are born assigned male at birth, those more often are going to have a pathological reason for early puberty if they show signs. So if the testicles start to get bigger at the age of 6 or 7, rather than 9, which is the earliest I would expect for someone assigned a male at birth, then that's when I would want to investigate things in terms of what the actual hormone levels are and what the hormone levels are from the brain. Um, so the way that these puberty blockers are working and the way that sort of puberty starts, I think is helpful to have a general understanding to sort of give you a way that the medicines are working, right? So you can think
Mhm.
about those side effects. So um, it's basically you've got the brain's got the pituitary gland. It sits right in the middle of the brain, sort of down here on the inside, the very center. And that's sort of like your major hormone regulator of the 5 major hormone systems of your body, one of them being your sex steroids or the estrogen or testosterone. And so what happens in terms of at times of puberty, the chemicals going to the pituitary gland would be your gonadotropin releasing hormone. So you're telling the pituitary gland to release gonadotropins. And so GnRH, gonadotropin releasing hormone. So we say we want some sex hormones. It's time to go through puberty. So you're going to
Mhm.
say release the luteinizing hormone, follicle stimulating hormone, LHFSH. Those are the gonadotropins. They actually go and talk to the gonads to say make estrogen or make testosterone.
Mhm.
And so that signal from the hypothalamus to that pituitary, that initial signal, the gonadotropin releasing hormone, it actually, at the time of puberty, is pulsatile. And so it comes in sort of waves, it goes up and down. So it's kind of hard to measure without doing specific tests for it. Um, but when it starts to get that pulsatility is when the gonadotropins, the LH and FSH, are going to increase until the gonads to start making the testosterone or estrogen. That's when puberty starts. So that's how those puberty blockers work, is they are gonadotropin releasing hormones agonists or mimics, the sort
Mhm.
of the same thing as that. So what happens then is that you get one steady state of the gonadotropin releasing hormone. just GnRH agonists at a steady state instead of going up and down. And
Mhm.
that's what holds off the puberty from
Got
starting.
it.
So it's just keeping the brain in this steady state, telling the pituitary to just not start puberty yet. And
Mhm.
as soon as you take away that GnRH agonist or the puberty blocker, then it starts getting pulsatile again and starts through puberty like normal. So that's how those drugs are working. And so that's what's awesome about endocrine is like, if there's not enough of something, then you can give it back. If there's too much of something, you can block it. And that's sort of what's is happening in this case is that you're blocking the pulsatility of it by sort of giving it at a constant rate. And
Yeah.
so that just pauses the puberty. And
Mhm.
so I think that having that good understanding of it really helps to see sort of how it's working and how it's not going to cause like permanent effects, how it's really just a simple pause on the brain. I
Mhm.
don't know if that answered what you were
Yeah.
asking.
No, it absolutely did because I think, in terms of like parents, I mean, we don't really, this is, I think, something that we don't know a lot about generally. Just like, I mean, there's so many things as parents that we just don't know a lot about. You have a baby and they don't come with a manual, right? I wish. I'm advocating that the placenta turns into a manual, but
That would be
taking
so
nails on it.
useful.
Yeah, it's so useful, right? But so I think there's a lot of things that are complex. So understanding how it works in the body, I think makes a lot of sense and can help parents to be more open to the idea of giving our kids that chance to kind of uncover this part or to have a pause to have more development happen, right? To see where they're at, to explore this a little bit more before they feel, committed to the gender that they were assigned at birth. And if that does not feel right for them, then it gives them that space to make different choices along with their medical team and their parents. Um, and so I think that's very helpful. So thank you. Can we talk about, I think just this topic of gender identity can be so complex and I think honestly scary for parents, right?
Mhm.
They may not have thought about this like it's like something that somebody else is going through and maybe not their own children are going through. Can you speak to maybe why you think that more teens or kids are exploring this gender fluidity now and how we might understand that if there's like a cultural part or developmental context to that?
Yeah. So when I was in fellowship, which was sort of during the COVID years, and so what I mean by that, I don't know if people have a good idea of how I got to be a pediatric endocrinologist, but basically, after your undergraduate degree, I also did a master's degree, which is just a bonus. But you do 4 years of medical school for most people, and then after that, you do a residency, which for pediatrics is 3 years. But then because I wanted to specialize in pediatric endocrinology, it's another 3 years of that training. And so that would be fellowship training. So when I was in fellowship training, there was some relatively recent articles that had been coming out about this phenomena of rapid onset gender dysphoria. And what it was is basically a lot of centers were just seeing a huge influx of referrals for uh, gender dysphoria or for gender affirming hormones or for whatever related to that. Um, and they were looking to see if it was more like a social phenomenon, and they really didn't find any factors that point into that. I think that the big things about it is that it's safer. It's safer now for our kids to be more of themselves and for them to come out, even if it's not necessarily safe for them in particular at their home. I mean, like as a society in general, it is safer. And that's why more adults seem to be coming out too. And so I there's nothing like it's not like growth hormone in the milk that's causing this, it's not like pesticides in the cornfields or whatever. It's really it's a matter of our societal expectations have changed, and so these kids are seen as they need to be taken care of and protected and kept safe. And so it's a little bit more acceptable to be able to come out and try to get the care that they need. I back in the day, it was just a matter of more people, hiding their true selves and maybe having other issues because of it.
Mhm.
And um, I think that the social contagion sort of theory just it, it's they try to use it. I mean, like critics try to use it in terms of like things like autism and ADHD and other forms of neurodivergence too. And it's just that we are able to see these things now. People are talking about them more. People are connected more than ever with how the internet is, and so it's not that we're having an increased number of diagnoses. It's really that we're seeing it more.
Mhm. So talk to me about statistically, do we have good numbers on like how many people assigned one gender at birth are feeling this gender dysphoria and feeling more comfortable in the opposite gender? Like
Mhm.
what is the likelihood? Like what's the statistics? Do we have numbers on that?
So I think that is a really difficult number to come across for a few reasons. And I think that one of the biggest reasons is that it is difficult to do research on this patient population.
Mhm.
It's kids in general are a protected patient population, so it's difficult to do research um, in general about children. But then also, there's so many other barriers to care
Mhm.
that it's so hard to know what the true number of kids who are gender diverse really is.
Mhm.
Um, I would say that like at a big center from where I was coming from over the span of maybe like 10 or 15 years, they had seen around at least 1,000 unique gender diverse patients at the hospital system, not necessarily for gender care, but
Mhm.
overall. Um, and I thought that that was a pretty big number, for one large referring hospital system. Um, but it's just the numbers have been going up over time. There's no way um, to look at that differently. But now you've got all of these different rules going on in like different areas with schools and things like that, where, kids can't even go by what their real pronouns are. They're required to be called whatever their birth certificate says or whatever. And so it just skews our statistics so much to actually see what's happening in the actual population of kids.
Mhm. Yeah. I mean, I was just thinking that like in the DSM, they have a very like the statistic is like incredibly small. And it was something like when I started practicing that like was quote unquote never seen. I mean, it was, but it wasn't. Right. And so I
Mhm.
think that piece is I think it's just helpful for people to know that it's not just like one person. It's not just like five people. That there are a lot of people exploring gender fluidity and also their gender expression, and and so it's. I want to say I hate the word normal because like that's it is an okay part of what people go through, and I want people to be supported in that.
I think that's a good thing that you brought up, that, it is different. The terms gender identity and gender expression,
Mhm.
as well as like sexual orientation or attraction, all of those things can be different. Sometimes they can be related for some people, but it's kind of hard for some people to understand that there is such a spectrum of gender identity, and how it is can be related, but not necessarily always related to an individual's gender expression,
Yeah.
and how those things also don't necessarily line up with chromosomes. You
Mhm.
know, it's really, it's just a terrible argument to say that it's biology, that there's only two sexes. It's just not true.
Yeah.
That's what you got if you just listened to everything you learned back in the day in school and didn't actually figure it out when you got older.
Mhm.
Um, you know, our health class wasn't the greatest back in the day.
Sure.
Um,
Yeah.
and so you know, it's not just genetic disorders that have those differences in sex chromosomes. There's tons of genotypic and phenotypic diversity that is possible. That it's just a very narrow-minded to think that you can just define biological sex by XX versus XY.
Mhm.
Um, and so that's a good point to make, in that all of those things are different. The chromosomes that you have, the phenotype, or what you look like on the outside, your gender expression, how you make yourself look on the outside, and then how you feel on the inside, or your identity.
Yeah. Yeah. And I think it can be hard. And I think, parents, I know we just want our kids to be happy and healthy. I mean, at least, like, right, like that's really what it's about. But I think a lot of times there's a lot of noise outside of our own homes that tell us about like what we should be doing or shouldn't be doing, whether it's about parenting or our kids involved in certain things or activities, or things like gender identification, sexual orientation, right? Like this fluidity around this can be really uncomfortable for people too, and confusing. And so I think, each person, I think there's a lot of times that when I interview people, they say, for instance, one person with cancer and you just know one person with cancer, right? One person with ADHD, that means one person with ADHD. And I think when you're looking at gender identity, that fluidness, right? That range is just one person that you know. So just because you know one person doesn't mean you understand everybody that may be having gender dysphoria. And I think that's an important part to mention, is that like everybody is so unique within this process. And so I'm glad that you're looking at each person individually about their needs and wants and desires, and also like from the medical lens of like what is also possible or what seems feasible or what the medical community can do to support this person where they are and what options they have.
Yeah, I just got back from this conference from the weekend. It was the Peds Endocrine Society conference, and there was some good talks about gender care, and a lot of good posters about peds transgender care. And one of the talks that I thought was interesting, that I was really looking forward to, but I felt like I left with maybe more answers, was talking about kids who identify as non-binary,
Mhm.
or or even agender. I What's interesting in terms of management of those kids from a hormonal standpoint is that we really do try to individualize it to the goals of that patient, and how those goals might change at every visit. I typically reassess every time that I see them, and I've got a whole goals worksheet that really, I think it came out of Oklahoma, and then a lot of other centers are using a similar sort of goals worksheet, where you can use, actual questions to say, all right, where where is this patient at in terms of their goals and how they feel for their gender today, and you can follow to see how it changes over
Yeah.
time. um, and I that's a really, it's a good way to, look at it. But then, having kids come to see endocrinology sooner rather than later then can be really helpful, like we said about the Dutch protocol. But also for some of those patients who are non-binary, it can be really difficult to come up with a good plan that is going to get them enough of one of the sex hormones to be able to get that good or bone mineralization that happens during puberty. And so the way that the researcher was presenting it was very much in that it's just nearly impossible to come up with guidelines for us to follow for
Mhm.
non-binary patients or eh, patients who are not necessarily strictly masculine or feminine, because there is such individuality,
Mhm.
and that we need to really try to focus on making sure that they are getting the hormones that they need to keep them healthy while trying to keep the gender goals in line as well.
Yeah.
And so I think that the recent articles, so like the DSM, um, I would say for transgender medical health professionals, we use the WPATH guidelines, or the World Professional Association for Transgender Health. Um, and their recent guidelines, I think, added a little bit more of a section for those non-binary patients, because it's difficult to have a good way to assess what's going on. But there are a lot of patients who are interested in that, and I think it's great that the this medical community is working on ways on how we can help best support them.
Yeah. Yeah, it's tricky. I think as, we're evolving, we're creating an open space for people to express themselves. Then for medicine to also follow that can be hard because I hear you saying that there are certain goals of puberty that we have to have happen that help our body long term. So, are there other things that happen besides bone structure that happen through puberty that are like essential that you can't skip out on?
Um, so I I would say that yes and no. So it is sort of related to the bone health, really.
Mhm.
So the main things that are happening during puberty. For boys, of course, you're getting the testicular growth and the testosterone going, and some estrogen going on, um, and that's going to help with the bone mineralization, as well as how tall they're able to grow,
Mhm.
and like their muscle mass and things like that, that testosterone helps out with too. But then for people who are assigned female at birth, that estrogen is going to help the uterus to be able to develop, to be able to start having cycles.
Mhm.
And so, while that, of course, can be important for fertility for some people, uh, that is also really related to the bone health as well. Is you need to be able to go through those cycles to have the right levels of hormones for your bones to be able to grow as well as mineralize correctly. And so it's all sort of wrapped in together in terms of like how much growth you're getting for height, the strength of your bones, and how much pubertal development you get.
Yeah. Yeah, which is an important process. But, like there are things that can, if you're non binary, then that might be something that growing breasts would not be something that you would maybe want. And so being able to balance that part out can be really important.
Mhm.
What do you think is a way that parents can respond? So let's say that their kid comes to them and says, like I want to I would like my pronouns to be they them, or they're assigned male at birth and they would like to be called she her, or to change their name to something else. How can parents um respond in a supportive, non-alarmist way when their kids are expressing these things to them?
That's a fantastic question, because I really like to be in a lot of different social media groups with other physicians as well, and it has been very interesting to see the sorts of responses from my colleagues as other physicians
Mhm.
can say to some prompts about this topic. Because I think that it probably mirrors some of the general population, but I would say that there is definitely a higher percentage of people in the medical community who are more supportive of gender affirming care for kids than not, because most of us, I would say, have been affected in some way or another by gender diverse patients. But there is still going to be different people in every uh, uh, specialty, and so sometimes there are physicians that I would see that could say things like, if my kid was questioning their gender, or expressing that they were a different gender or something like that, that they would that it would be more affirming and more supportive for them to say, you are perfect just the way you are, and you shouldn't need to change your gender, which is an interesting argument. If somebody is, gender diverse, then obviously that's the way that they are, and they should need to change that. But I see that as an argument that, and we sort of touched on it earlier, where kids, might want to try out different things, or
Sure.
they might identify as a cupcake. Like my kiddo, who was going by they them for a while, and most recently has been going by she her. At one point definitely identified as a cupcake, and I'm like, I mean, that stuff like that, like, very obviously that is child, like, make believe and pretend
Mhm.
and fun, and you can still play along with it and be supportive of that. And like, if a kid hands you their fake cell phone and says that it's ringing for you, you better pick up and answer it, like, whether it's a real phone or not.
Sure. Yeah.
So that's really what I mean by being supportive of your kids. Like, sure, you can say that I think that you're perfect the way that you are, but you can also say that I'm going to support you however you need to change for you too. um, and so, I think it's fine to try to give your child pride in who they are as a
Mhm.
person, and how they were born, or however they are at that point in their life. But there's the other piece of supporting them in terms of their growth and their goals, and what brings them joy.
Mhm.
And it might not necessarily always look like how parents expect. And so I feel like that also leads me to a topic that sometimes gets talked about in some of my um, doctor social groups, is I feel like, especially for uh, childbearing folks who are in medicine, we end up having kids later on in life, because we've been so busy with careers and things like that. And so there tends to be a lot of people who are doing, like, in vitro fertilization procedures and
Mhm.
things like that. And a lot of folks ask, about how they can try to get, a particular sex, like an XX or XY chromosome profile for the child that's the egg that's being chosen for the in vitro fertilization. Um, and I can understand how some people can have certain expectations of what they wanted in life, and how they imagine their children to be, and things like that. But when you look at something like that, like, oh, I'm really, like, myself, I have four assigned girls at birth. And so, a lot of people would ask me, well, don't you want a boy? Like, and I really struggle with that, because I don't necessarily say that every baby needs to be, like, non-gendered, like everything needs to be non-gendered. Folks can do whatever is going to be making you happy, but, like, it is just so important to keep in mind, just like you would for any other part of your child's life.
Mhm.
If you really wanted them to become a football player, but they decided they wanted to be an astronaut, like, you're still going to you need to support them through that. And
Sure.
I feel like that's similar with their gender identity too.
Mhm.
Is you can try to tell them that they are great how they are, and you definitely should. But also, it's totally fine to just accept them if they start saying that there's something else, and just see where it goes. And if it's something that comes up often, and is pretty persistent in terms of that difference between their perceived gender identity and what their assigned gender is, then that would be the time to talk with your doctor, to see about, hey, like, should we try to work through this with a therapist? Is it time to see the peds endocrinologist to maybe think about what possible therapies in the future could be?
Mhm. Yeah. Is there too early of a time? I mean, so if you have like a 6-year-old who is assigned male at birth, and is saying like, I really think I'm a girl, or I want to be a girl, or I feel best when I wear dresses or something like that. Like those are things that I know that kids have said.
Mhm.
Then is that too early to see a pediatric endocrinologist, or is that okay? Like what are the guidelines around that?
Yeah, I think that having the referral to Pete's Endocrine would be best to do whenever. So it's going to be really different at different centers, and if
Mhm,
people even have access to a pediatric endocrinologist um, who is comfortable with gender affirming care. And so that's why there are some campaigns to try to get like adolescent medicine doctors on board, and there are some family medicine doctors who are trying to help with that shortage as well. But if you have the option to be able to get referred to a peds endo, I think it would be good to get introduced to them, and just talk about where things are at that
mhm,
time. And then you can talk about what some of the possibilities could be for in the future.
mhm,
And then you can sort of leave it open from there of, well, we can keep following you maybe like every so often, if we're sort of getting close to puberty time,
mhm.
or you can just call us when you think, when your regular doctor has noticed maybe puberty is just getting
Sure.
started. And, there's a few different ways to go about that. But I think that whenever a kiddo is expressing that they're a different gender early on, and it seems to kind of be sticking around, then I think it would be great to just talk with us and get an idea of what the options are.
Yeah, that sounds like good advice. Okay, so from your perspective, do you think that there is a difference in curiosity, exploration, or long-term identity decisions? Like, is there a difference in those pieces in terms of how it presents in our kids?
Um, I would say so. It's honestly it's changed over time. So when I was first getting started in fellowship, and so that would have been like right before COVID. It was sort of those earlier 2000s and 2010s. I think that it was a little bit more looked at differently. Um, and it seemed a much more final when you're going to the endocrinologist, like, okay, well, that's what the plan is going to be. But I think that now that's just it's gotten different over time.
Mhm.
And I don't think I remember what the original question
Well,
was.
so
So
I was
maybe
asking about the difference between being curiosity in terms of gender
I see.
exploration and then long-term identity decisions, like where you're making something in terms of endocrinology wise or
Mhm,
surgically. I heard you say that like generally in childhood we're not doing surgeries, right? That's an
mhm.
adult decision at this time.
Mhm. Yes, yeah, exactly. And so, in terms of like the curiosity part of it, it, you know, all kids are going to go through something where they're figuring out their gender. And like I said, that's sort of those first pieces that are at like 2 or 3 years old. Um, but in those early studies that we looked at, there was a smaller percentage of those patients that had those saying that they were a different gender at the 2 and 3 years old, who then went on to continue to have gender dysphoria like in their teen years.
Mhm,
Um, and so, what it seemed like in terms of longevity is that those kids who were younger maybe didn't always continue to have gender dysphoria, but the
mhm,
kiddos who sort of came out with the symptoms in adolescence would then be much more likely to continue to take the gender affirming care as an adult.
yeah.
And so that was part of the research that I was trying to look at when I was a fellow. And it's just, there's so many different obstacles that made it hard. But one of the things I was looking at is how many people ended up getting started on either estrogen or testosterone
Mm,
in terms of for gender affirming care, and then how many people then continued to take it once they became an adult.
yeah.
So basically, I was trying to figure out sort of detransition rates, or basically
Mm,
people who stopped gender affirming care. It was a very, very low number. It wasn't something that really was publishable, but it was my research project. So it was interesting, interesting to look at. And I think that that gives us, a good idea. But like I said, it could be that the studies are going to be different now in terms of the number of kids who are having those gender questions at the young age versus when they start having them at puberty, and if it will persist over time, or versus just being like a curiosity that they want to try. I think that it's very possible that those statistics could change, but that is what we were taught previously, was that, they may be a little bit more curious and questioning when they're younger, but typically then by the time they get to like 4 or 5 years old, then they end up sort of being a little bit more solidified in that. But, I think there's just got to be some more research in terms of seeing, okay, now what about kids who are growing up in this day of age who express gender differences at this young age of like 3 years old or so? How persistent are they in their gender dysphoria when they get to the teen years? I think that's some new information that we're looking at. But I really don't know. In terms of my thoughts, I feel like that doesn't matter as much to me, because I feel like it's the same thing in terms of supporting them as they're growing up. Because, once they become an adult, they're going to be able to transition or do whatever they want by then. So, it doesn't matter to me if the 2 and 3 year olds don't always persist in their gender dysphoria, because those aren't the kids that are going to come to see me and ask for hormones and puberty blockers. What I want to know about are the kids that I am getting started on those medicines, which in terms of when you do get started on the gender affirming hormones can be 16 years old, typically for WPATH, but in some cases can be as early as 14 years old for sort of, I like to say, like slam dunk cases, like they knew that they were the other gender or a different gender since they were talking and stayed that way all the way through childhood and then into puberty. And then if they get to 14, then especially for girls, kids who were assigned male at birth, the girls that are their age, their peers are going to be developing, at like 10 to 12 years old, like we were just talking about. So if that transgender girl can't get started in puberty until 14 at the earliest, if she has always, been steady in that identity, or 16 in most cases, or even 18 in some cases, if they've got some other things going on, if there's some other mental health issues that aren't related that need to be taken care of, it's hard, because then they're going to stick out like a sore thumb, for those first couple of years where their peers are developing and they aren't. And so that's where it gets sort of tricky in terms of when you're deciding to do that gender affirming care and deciding to start on it. But yeah, we're definitely looking at more research to try to figure out, how long it does persist, but it is a moving target.
Yes. Okay. So question. So let's say that we do the hormone related care and they do detransition, but we haven't done any surgeries or things like that. Is there a negative side effect that can have in life?
So, for estrogen versus testosterone, they're going to have their own unique permanent side effect risk that we always go through before getting started on either of those. So, like uh, for like something like breast growth, that's something that typically once it grows, it's not going to go away most of the time, that you would probably need surgery to make it go away. Things like I feel like I'm a little bit scattered, but usually I'll just sort of like go through and like list for
Yes. Sure.
each one. So like, of course, there's for like voice changes. The voice isn't really affected as much by the hormones, which is why we typically often recommend voice training with like a speech therapist.
Oh,
So that's not something that is typically a permanent change. For testosterone, it'll have sort of the increased hair growth, and that typically won't really go away. Like those hair follicles are still going to be there. They might kind of soften up a little bit when you take away the testosterone, but it's not going to like stop being having those increased hair in those spots. Um, some other things that we look at would be like the liver function of just getting treatment with those hormones. Most medicines are going through the liver in terms of metabolism, and so you want to make sure that you're not affecting the liver by giving those medicines. But that's typically not something that's permanent either. I'm trying to think of what other things are permanent. I should just bring up my list and make sure I'm not missing anything. So I've got it printed out right here. So because you've got changes, right, that are going to be permanent, but then you've got things that will go away too. And yeah, the dyslipidemia. So sometimes you can have the cholesterol changes that would also get better when you get off of it. Yeah. I'm trying to think of what other like permanent things. The thing about it is when you're treating with these sex hormones, you're not giving extra compared to what the physiologic or what the baseline normal should be. And so it's not necessarily like you're giving yourself an increased risk of heart attack and stroke by taking estrogen. It's that you're putting your risk of heart attack and stroke at the same of like a cisgender woman who is going to have those same levels of estrogen, but then it's going to be more than what a cisgender man's risk would be. If that sort of makes sense. And so because it's not supra physiologic, you're not giving extra hormones, then there's typically not as many like long-term side effects other than those physical side effects that you're going to be seeing. I think that's mostly what I'm trying to get at, is that there are those physical side effects that can stick around, but that's something that would probably need to be changed with surgery later on if they decided that they did not like those side effects. It is very possible, but that is what we try to prevent in terms of the referral process and making sure that they're following with a therapist and things like that.
Yeah, doing your due diligence ahead of time, which
Right.
totally makes sense. And I think, hearing the numbers that you're quoting, that like the detransition rate is actually pretty low, that most people that have gone through that process it's not going to be a lot of people that are going to go through that detransition piece. But I think it's also just helpful for people to know, right, that they're to be thoughtful about that, to make sure that that's what they want. And that's what we're seeing you for, right? Is to talk through those risk, side effects, and complications of any medication that we're putting in our body. That's what doctors help us to understand, is like, is this with the goals that you have, let's say controlling our blood pressure, we take this medication, what are the risk, side effects, and complications of that? It's, is that worth what our goal is, which is a blood pressure control? Same with gender identity affirming care. Sorry. Is
Exactly.
that we're looking at that to this is what the treatment would be, and is that risk, side effects, and complication in alignment and worth what your goal is? Do those feel good for you? And if they do, we proceed. If they don't feel good, then we stop. Right. And so I think that that's great that you're constantly assessing the kiddos that you're seeing to make sure that we're in alignment with where they want to be. So I'll end with this question. I think, it can be really overwhelming to be in this process. And sometimes, when I talk to kids about, this is a different topic, but sexuality, right? Like they may be thinking about that for a long time. And so they maybe have come to a place where they are comfortable with where they're at. But then when they share the news with their family or friends, sometimes there is not radical acceptance, right? Like there's that piece of like, I have questions, or like, I want to know more about this, or like, I got to process and metabolize this. And so I think parents can sometimes need some time to process, which I think is normal. I think when you hear something that, like your kid says, I'm going to move to India, and you're like, wait, hold on. Where did this come from? I have questions, right? And so it feels like it's something surprising. Then it makes sense that you need time. But ultimately, we just want to support our kids, right? And so thinking about their gender identity and where they're at with that, how can we, if our kid has come to us, how can we support them in powerful ways to just like show up, express love? Like, what can we do to make sure that as we're like metabolizing this, we're able to continue to support our kids, that our stuff doesn't get in the way of their process, or interfere with them being able to express who they are?
Mhm. I think the biggest thing for kids to see from their parents is that their parents are trying, you
Mhm.
know, that they're trying to say use the right pronouns, they're and not just like that they say that they're trying, but like actually trying, saying I love you no matter what, and I'm going to work on processing my inner feelings, but I will always support you no matter what. I think is sort of the important piece to show to them, to sort of be able to have that parent face for them, to show that you are going to support and be there for them no matter sort of what inner turmoil you may be having. um, and then do the extra piece to then go through and do that work with yourself as the parent, like it can be a lot of different feelings, when your child is maybe different than what you expected them to be. And I think that going through and learning about why you've got those thoughts about your child and where they're coming from, and trying to understand them for yourself while maintaining that connection and support with your child is the most important thing,
Yes, absolutely. Well, thank you so much, Dr. Baldridge, for talking us through this process and how to support our kids, and also
You're
just
welcome.
for doing what you do and being out there and helping our community.
Thank you, and thanks for having me. I love to share what I do. I'm a little bit of a nerd about it.
Yes, I love it. Thanks again, Dr. Baldridge. I so appreciate all of your information. I hope that you have gained some information. And I also am proud of you for listening to this episode. If your kid is going through identity exploration, and how to show up most powerfully for your kid while understanding the science behind what can happen in gender affirming care. With that, I will say thank you so much for your time today. Please subscribe to our show. If you will just take a moment to click the button, it's generally on the right hand side, and it says follow this show on whatever platform you listen to. That would be amazing. I would so appreciate it. The other thing I will say is, if we have had an episode that you really feel like made a difference, or the information was incredibly powerful, what I would ask is that you share it with a friend or family member to help them hear what we're doing on this show and to impact their life positively. With that, I will say thank you so much for your time and have an amazing day. Some words from our legal team.
The information presented in this podcast is not intended or implied to be a substitute for appropriate professional advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained on or available through this podcast, is for general information purposes only. This podcast makes no representations and assumes no responsibility for the accuracy or information on or available through this podcast, and such information is subject to change without notice. You are encouraged to confirm any information obtained through this program with other sources and review all information regarding any condition or treatment with the appropriate professionals.
What we're saying is, yes, I am a real therapist, but I'm not your therapist.